belief. What do you believe in when it comes to your job, when it comes to the NHS? What do you believe in? I believe that people are innately resourceful, and we often don't recognise that. I believe that personalised care is just good care, right? It's nothing special, it's nothing strange. It's really just good care. I also believe that we've, not us, many people out there, kind of lost their way over the last few years. You know, to care is our core mission. I don't know if any of you know Victor Montori. He speaks so persuasively and with such energy and with such power about care, just caring. So I believe that's our core mission. I believe we kind of strayed off path, and I also believe we are at the vanguard of people who are going to get the path back on track. We're the leaders. We're the people who are going to make sure that care is at the heart of the way the NHS does its business over the next generation, 2 generations, forevermore. So my thesis for this 10-15 minutes is that medicine's kind of running out of steam. There are some fantastic innovations in medicine. It saves people's lives, it mends broken bones, it helps people get back on track. But we've medicalised care for far, far, far too long. And I would love to think, we would all love to think, that working in the NHS, experiencing the NHS, is like an alpine meadow. Fluffy little lambs gambling around. It's like that, isn't it? It really is like that. I see all the nods. Yeah, if only it were like, but it should be like that, shouldn't it? Really, it should be like that. But for patients, people, we do a lot of stuff and we know it's wrong. I worked on the National Overprescribing Review in NHS England a few years ago, and the maximum number of different sorts of medicines that someone was on was 57. Can you imagine being the prescriber who prescribed the 57th medicine? What were they thinking? All the 56th, all the 55th, yeah, etc., etc., etc. Yeah, we know that people are on too many pills. There's this thing called treatment burden. If you've not read about treatment, but I'm sure many of you know about it. You know, living with long-term conditions is a burden. It makes life tough, it makes life difficult. Very often in the NHS, we add to that burden. We don't relieve the burden, we often add to it. Treatment burden. We often do this thing called cascades of care. If you order a test, or a number of tests, often what happens as a result of that test, especially if we do them in people over 65, 70, is that they're not quite perfect. So we end up ordering more tests. We end up with more referrals. So these cascades of care lead to more and more treatment burden. And sometimes we've just got to stop and go, oh, what are we doing? Perhaps this conference is that what are we doing day. Because it's not just harming patients, it's harming us. The moral injury that we see in the NHS now is, God, I started in the NHS in 1978, and it's never been as challenging and as tough as this. But we know, all of us, that the more we practice personalised care, the more we reconnect with our core mission, and frankly, the easier it is for us. But let's look at what the source of some of this, frankly, chaos is. I'm just going to pick on one kind of sliver, one lens here. This is how much we're spending on the NHS. Health in general, about 185 billion it is now. The majority of that goes to NHS England. for health. Little bits goes to public health, Office for Health Innovation and Disparities. But look where the spend is going. As we age, ageing along the bottom, spend up the side. And we're still spending so much more on hospital care than we really should. People in their 70s, 80s, 90s going into hospital. There was a fantastic review by Angela Coulter a few years ago in the BMJ demonstrating that people who have more than one condition in hospitals get less good care than people who just have one condition. So for all sorts of reasons, it's not the right thing. And of course, we've been trying to bring care closer to home for 25, 30 years and not desperately succeeding. What we do know now, speaking of long-term conditions, is that 56% of our adult population lives with one or more long-term conditions. This was from Future Health 3 months ago. And 25% of our adult population live with 2 or more long-term conditions. So we are living longer and we're collecting more and more and more long-term conditions, and it's costing more, and the majority of the cost is in hospitals because we've got a primarily biomedical system. And look at this. This is the Office of Budgetary Responsibility. If you look at the increase in spending pressure year on year, and look across the bottom where that pressure is, so prescribing services, community services, primary care, secondary care, it's not demography that's causing it. People always go, oh, it's ageing, that's the problem. It's not ageing, that's the problem. Actually, the primary problem, frankly, the secondary problem, is the number of long-term conditions we have. But the primary problem, that blue box, is our response to it. We make our services more and more and more complex. We make our systems more and more and more complex. We thus make it harder for patients. Why do we need care navigators? It's because the system's too complicated. That's why. And it's adding cost, and it's adding, frankly, low-value cost. Isn't that amazing? It's not age, it's not multimorbidity, it's the system response that's the problem. And look at that again. It's a few years old now, but David Eddy, a great commentator, has talked about the increasing complexity and intensity of clinical practice. And that's way, way, way more of a concern, more of a cost driver than ageing, multimorbidity. It's the way we organise our services. And I often say that the NHS is now like a 75-year-old Christmas tree, full of baubles that we bought in the 40s and the 50s and the 60s and the 70s. We have an additive way of thinking about innovation. Innovation adds complexity, adds cost. Whereas actually the very definition of innovation is it should reduce complexity and reduce cost. So we got it all wrong. So what can we do? Well, the tide's turning. We now know that the biomedical approach has got significant limitations. We all know that. We all know that. There's loads and loads and loads of slides from, newspaper headlines from over the last 4 or 5 years. We know that people with anxiety and depression, we know that people with chronic pain, we know that people with insomnia, we know that many people with diabetes don't necessarily need medicines. And I think what we're starting to do is recapture the spirit of what George Engel in 1978, the year I went to medical school, described as the biopsychosocial model. It's a dreadful word, but it really is about seeing people as the sum of the biological, the psychological, and the social. And those factors are the determinants of our health and of ill health, but ill health has an impact and consequences, not just in terms of the biological, but the psychosocial. So we're at the vanguard of reclaiming Engel's vision. We're at the vanguard of a significant shift now. I think more significant than I've seen it in the last 40 or 50 years towards a much more holistic whole person living in the context of their family, their friends, their communities. We're at the vanguard of that. We've got to keep going. It's kind of tough right now, but I promise you, we're making the difference. I talked about people in their communities. If you haven't read it, read Realising the Value. It was a Nesta and Health Foundation publication talking about all the stuff we're going to talk about today. It came out in 2015 and promptly sank because there was a new team in NHS England and they wanted to kind of start things afresh. But do look it up. Do also look up Patient Priorities Care. If you don't know it, it's in America. What it's actually about is for people who live with multiple long-term conditions, saying to them, what is your one priority? What one thing could make your life better? And then reorganising the system to help deliver on that. Kind of coaching, but actually systematised. So, I believe there is hope. This is not a political slide. Promise. We're going to have a new government, right? We're going to have a new leader of the health system. Now's the chance to reset, and it's up to us to contribute to that reset. Thank you.